Another category of patient who responds very well to manipulation under anesthesia is a person who has failed the normal course of care. So maybe they've tried chiropractic, maybe they've tried physical therapy, maybe they've tried injections, pain medication. At this point, they're at a crossroads. Nothing has worked for them. At this point, they very often go for spinal surgery. Either they have decompression surgery where they are putting various rods and screws or bone in the spine to stabilize the spine. But over the last 10 to 15 years, they have been having a procedure that is more minimal than that. It's called a discectomy. And they'll just go in and remove just a little piece of the bone and then take out the herniated disc that has been inflamed and causing the patient's pain. The problem is very often it is no longer the herniated disc that's actually causing this person's problem. If you ask the patient who has the herniated disc and you say to them, "Do you have pain all the time?" They say, "No, I don't. Sometimes I have the pain, sometimes I don't have the pain." Months can go by where they don't have the pain, and months can go by where they do have the pain. The truth of the matter is when they don't have the pain, they still have the herniated disc. So it's not really the herniated disc that's causing their problem. It's the inflammation in the area when the disc inflames. Now, there's a category of patients where there's so much scar tissue in the area, it's actually the scar tissue that's causing their pain and not the herniated disc. So when they go in there, remove a piece of the disc or remove the part that is bulging, then they come out of the procedure and they don't feel any different. This is called failed back surgery syndrome, and it occurs, the literature shows it occurs about 30% of the time. What happens is normal tissue is aligned in a linear fashion like this. But once that tissue's been torn, a fibrous scar tissue knits it back together, and it's more in a crisscross fashion, which leaves it shorter and thicker and denser and less biomechanically advantageous. Because this tissue is easier to tear, the body lays a significant amount of pain nerve fibers into this tissue, and so that tissue becomes very painful. When we work on this tissue, we actually begin to open it back up. And now new scar tissue forms in the area that we have just opened up. And so when that scar tissue forms in there and the patient continues after the procedure with the stretching exercises that we give them, or if they choose to go back to a physical therapist or a chiropractor to continue their rehabilitation, that scar tissue now fills in with the scar in a much longer, thinner, more flexible state. And so the procedure actually becomes a permanent answer for the patient. It does not sling back to the way it was before. We have opened and lengthened it, and now it fills in with the scar much longer and more flexible than it was prior. This 30% of patients was having their pain as a result of the scar tissue infiltrating various tissues such as the dural sleeves, the joints, the area around the disc, the muscles, and so forth. And these patients are phenomenal candidates for manipulation under anesthesia because now we can get in there and reduce the scar tissue in and around the injured areas, and now these patients respond phenomenally to MUA. So those that have had minimal disc surgery or a discectomy, those are the ones that respond fantastic to MUA.